My name is Cindy Lopez, and I'm the Director of Community Connections here at CHC. And so Community Connections is the group at CHC that's responsible for putting on events like this, parent education, some teacher education. We also go out into the community and do similar kinds of things. So we're really glad that you're here tonight. How many of you have been to one of our community education sessions in the past? Okay, wow, okay. So thank you all for coming. We have some new people tonight, that's great. Before we get, I'm going to talk just 3 or 4 words about CHC. But before we do that, let me just introduce our panel this evening. So we have Glenn Elliott, who's our chief psychiatrist and medical director here at CHC, who has a wealth of expertise in ADHD. So we're really thank you for making time to be here. And Kendra Freka, who's licensed social worker, who has specific expertise in behavior analysis, and so really glad that she's here tonight too. Thank you. And Lauren Sims, parent, and whose team for her son includes Glenn and Kendra, and also she's our chair for our outreach team here at CHC, which is our volunteer work here at CHC. So we're really thankful that you guys have, that you're all here, that you've made the time to be here, and also that you're here. I'm sure you'll you'll appreciate and value what they have to say. Just quickly, some things about CHC. So CHC has been here in Palo Alto for over 65 years. So we're very community-based, community-oriented. We want to know what's going on in the community, and we want to help meet needs in the community. All kinds of things that we want for the kids that we see here. I'm not going to go over all that, and our mission is to remove barriers to learning so we can help children, teens, and young adults become resilient, happy, and successful, home and at school and life. And specifically barriers around in 3 areas, which is language, location, and ability to pay. So we have a lot of bilingual clinicians and even some Mandarin speaking. And we have different locations. So we have this location in Palo Alto. We have a location in South Bay in San Jose. And then we also do some work in East Palo Alto and Ravenswood. And then finally, we also are able to offer financial assistance to families who need it. And we do all of that. We look at every child as a whole. So we're not just looking at specifically challenges or a specific academic need. We're looking at the child as a whole. And that's part of the beauty of this team that you're seeing up here tonight, is that it's interdisciplinary. We have 4 areas of excellence. So we look at ADHD, learning differences, anxiety and depression, and autism. And we do it in 4 divisions. So we have 2 schools. If you have specific questions about schools, any one of us can answer those questions later. And then we have our clinical services, which Kendra and Glenn are a part of. And then we also have community connections, which is part of what you're experiencing tonight. So we also want to know and want people to feel safe here and included. So CHC is a place where everyone is welcome. So with that, I'm going to say one thing. There is a survey. You got it when you came in. You can also fill it out online. So these slides will be posted to our resource library probably next week. And so you'll be able to access it all, and you can also access the survey that way too. And I'm going to turn it over to Glenn. Glenn's just going to share, give us a little context and information around ADHD.
Yeah, this is going to be very, very brief. I'm assuming that most of you already know what ADHD is, but we're going to talk about that briefly, and then a few things that we know, good and bad, about having this disorder. So ADHD keeps getting redefined, but for probably the last 25 years, it's basically been defined as two broad clusters of symptoms. One has to do with attention and distractibility. The other has to do with impulsivity and hyperactivity. And you can have children who have one or the other or both. The overall diagnosis is ADHD, even if you're only distractible and distractible and have trouble focusing, and people sometimes get confused about that. There is no ADHD, no ADD these days. It's all ADHD. If you have both, you call combined type, and if you have just the hyperactivity and impulsivity, which is much more common in young kids under age 6 or 5 or 6, then it's called mainly impulsive hyperactive. It has to be present in at least 2 settings. This is really important. This is not a disorder that shows up magically in one setting but doesn't show up anywhere else. Usually we talk about school and home, although we have plenty of opportunities to see it here at CHC as well. The idea is that this is something that's intrinsic to the child. Obviously, environment can have an important impact, and we'll be hearing about that. But all of the things being equal, these symptoms should be present in a variety of settings. And they shouldn't just appear. We actually think ADHD is probably something you're born with. What happens is eventually you reach a point where your non-ADHD peers don't have those problems, and you continue to have issues that cause difficulties in one setting or another. Currently, the cutoff is you have to have symptoms, not necessarily a diagnosis, but have to have symptoms before age 12. It's a little bit arbitrary. The reason for that is kids with only inattention and distractibility often don't really begin to have problems academically until they get into 5th or 6th grade. So they may be 10, 11, or 12. So they used to be 7, and they realized that they were really excluding some people. And it has to cause problems. If your kid's not having difficulties, then they don't have a disorder. So I'm not going to spend any real time on this. Unfortunately, I would that we had a blood test. We don't. The way we make this diagnosis is really very simple sets of questions. If anybody here was ever a Sopranos fan, there's this lovely time when Tony Soprano was sitting with the school counselor saying, "So you're telling me that what we found, what we just told you, you're saying because of that, my kid has ADHD." The counselor didn't know how to respond. Anyway, but the answer is yes. We are basically relying on parent report, teacher report, observations of other people, direct observation, looking for these kinds of issues. If we had more time, I have a child who's now 35 and doing very well, thank you, who pretty much fit all of these categories, and I could give lovely examples, but I won't. The other category is the hyperactivity, impulsivity. Most of this tends to actually be more on the impulsivity side, even though there are more criteria on the hyperactivity side. These are the kids that get up out of their seat without permission, who wander around, who can't sit still, who can't make it through dinner, those kind of things. So what do we know about ADHD? One of the questions that people often ask is this a lifelong disorder? And the answer is it partly depends. For some people it is, and for some people it's not. It certainly is a chronic disorder. It is not something, we used to think when I was in med school back in the 70s that it went magically away when puberty hit. And what does seem to go away when puberty hits is the real major hyperactivity. That typically lessens and becomes restlessness and fidgetiness, but really isn't nearly as dramatic as what we see with younger kids. The impulsivity and the problems with attention tend to improve, but continue to be an issue for most kids. Roughly a third of individuals either outgrow ADHD or defined ways of dealing with it so it doesn't cause impairment anymore by the time they're in their late teens or early 20s. Another third continue to have major symptoms potentially for their whole life. And then there's a middle third that have some symptoms that are not as bad as they were, but they're still there. So usually your whole numbers, depending on whether you're a pessimist or an optimist, if 40% to 60% of individuals do or don't have ADHD for their life. Again, I'm not going to try to go through all these numbers. Estimates of ADHD really depend on where we make the cutoffs. There was a point at which the estimate was as low as 3%. We realized that was too strict. Current estimates are roughly around 10% of school-age kids will have some form of ADHD, one of the three types that we talked about. As I mentioned, 40 to 60% will have ADHD as adults. The male to female ratio, again, varies depending on where you look. If you look at a pediatric office, it's roughly 10 to 1 because boys are much more likely to be sent to see pediatricians than girls because I don't know why. We're so well behaved, I don't understand. Anyway, boys tend to do things that teachers don't like very much, and they talk to the parents and they get sent to the pediatrician. If you look at classrooms, it's a little closer. It's more like 4 to 1 boys to girls. And if you look at the general population, it's a little lower than that even. And it depends a little on the subtype. So if you look at the so-called inattentive subtype, that's actually very close to 1 boys to girls. Girls seem to be particularly prone to that problem. The point I just made is the reason they're in the pediatrician's office is that the boys tend to get referred for treatment. Girls tend to get diagnosed later. They often, particularly the inattentive type, whether it's boys or girls, tend to get ignored. These are the kids that are sitting in the back of the room. They're not causing trouble. They're not giving the teacher grief. And you'll see lovely little notes at the bottom. I'm sorry, Cindy. I would know you would never write such a note, saying, if only Johnny or Jill would just pay more attention in class. There's so much more that he or she can accomplish. And the reason for that is because they're having trouble focusing and paying attention. There aren't any major ethnic differences in terms of if we go and look at various populations, the ethnicity doesn't seem to play a role. There are huge differences across different countries about how often it's diagnosed, and that has to tend to more what gets counted and not counted. We think that the so-called true prevalence, if we had a single definition that we applied to everybody, that is probably present around, really in all countries at about the same rate. Good news, on average, over time, the symptoms of ADHD become less severe. And that's pretty close to universal. There are, of course, exceptions at the extremes, particularly kids who are very, very severely affected. But in general, things get better with time. Also, we found a variety of interventions, some of which we'll be talking about later, that can clearly reduce symptoms, partly medication, behavioral kinds of interventions, structural interventions. All of these things have been shown to have potent effects on the degree to which ADHD causes problems in a particular setting. One of the things that we're coming to grips with, because psychiatry doesn't usually think about disorders as having strengths, we usually focus on the problems, is that ADHD, if you can survive childhood and adolescence, ADHD can actually offer some real strengths for adults. My younger son has pretty significant inattentive ADHD, and he actually is a nice example of somebody who's managed to find nice ways to make good use of some of those characteristics. One of them is so-called hyperfocus. In spouses, it's called spousal deafness. You may be familiar with it. And that's not so great if the kid is supposed to be turning from one topic to another in school, but it can be really very useful in an intense situation where you need to get a project done. These people are very popular in startup companies around the Bay Area, for example. The bad news is that none of the treatments that we currently have, even though they can affect the symptoms, seem to affect the long-term course of ADHD. That seems to be determined by the way the brain develops. Also, inadequately treated ADHD is a major obstacle to other kinds of things that we expect kids to accomplish during those early years. Further, only about a third of kids have just ADHD. The other two-thirds tend to have at least one, and sometimes 2, 3, 4, and even 5 other diagnoses. So you might have a learning disorder, you might have a speech and language problem, you might have what's called oppositional defiant disorder, you might have anxiety. Any of those things may be present with the ADHD, and those kids tend to have more difficulties just simply because they've got more things going on. And the last thing I'd really like to emphasize is that all treatments have the potential for side effects. Certainly that's true of medicine, and people get very focused on that, but it's equally true of other kinds of interventions. You have to be very careful about the degree to which you're helping the child as opposed to causing problems. And I'm sure we'll get into that in other ways. So general points, ADHD is a chronic disorder. Impairment takes a lot of different forms, and those are going to change over time as expectations change. So I mentioned that ADHD gets better with time. The other thing that changes with time is social expectations. What tends to happen is kids end up seeking, or parents end up seeking treatment when those lines cross, when the social expectations, often at school but not always, exceed the child's ability to meet those expectations. And as I mentioned, there's a lot of different ways to help, and frankly, that's part of why we put this panel together, is to really emphasize that this is not an either or. You don't have to choose one or the other. Your child can get tailored treatment. I'm not going to spend any real time on this. This is a thought experiment I did some years ago that I just like. There are only so many ways you can intervene in somebody's life to make a change in the way they're behaving. And the highest level is structural and environmental. So that means maybe in the type of classroom that you're in, the number of children that are around you, a variety of those kind of things, how much routine you have, those kind of stuff. Programmatic sort of goes with that, and certainly Kendra will be talking about some about that. So those are environmental kinds of things, and they can be extraordinarily potent in treating ADHD. There's a guy named Bill Pelham who showed years ago now, decades ago now, that he could create a highly structured summer camp that was as effective, if not more effective, than medication. And the kids did beautifully in it. The problem is, as soon as they got out of the camp situation, the benefits faded pretty rapidly. Bill Pelham, P-E-L-H-A-M. He's at University of Rochester in New York. So he likes the cold. Anyway, the second is psychological. With young kids, this is not an area where ADHD really gets affected very much. With older kids, cognitive behavioral techniques, by that I mean teenagers, sometimes can really benefit from cognitive behavioral ways of dealing with both their ADHD and perhaps some of the other issues that come in. So-called intrapsychic psychotherapy kind of models don't really affect ADHD, but may affect, again, some of the other conditions that children may have, like anxiety or depression or self-esteem, those kinds of things. And then the last area is biological, and certainly medications is one area that's been very well researched. There's also, I know, an enormous amount of interest in nutritional changes and the impact of diet and those kinds of things. With very young kids, there's suggestions that diet can make a significant difference. As kids get older, by the time they're 8 or 9, the evidence for the vast majority of kids that extreme changes in diet necessarily change ADHD or get smaller and smaller. And also the ability to control diet gets harder and harder as kids get older. This you're not going to really be able to see, but we actually have begun to be able to map out some of the pathways that we seem to affect different aspects of ADHD. And one of the most interesting aspects of this, which may be exceptionally hard to find, is something that we'll be talking about, I suspect, Kendra more than I, is executive functioning, which is not ADHD, but often seen with kids with ADHD. That's the ability to carry out complex tasks in an efficient and orderly manner. That turns out to have a whole different pathway in the brain, and unfortunately right now, none of the medications that we've got certainly none of the medications that we've got have any effect whatsoever on that aspect of the problem. So, summary, ADHD is a disorder that can be chronic, but very responsive to treatment in the acute term. Medications can be certainly a very important component of treatment, but not an invariable one, and there's really a fair number of options that exist. There are other options and approaches that are really needed to optimize treatment for a lot of kids. And complicated cases demand really persistent reassessment, systematic approaches, and sort of trying to sorting out how much of it's ADHD and how much of it may be other disorders. And this will be available, as Cindy mentioned, in the site. There's a couple of slides that just have resources, both a variety of books and some websites.
So we are recording this, so there will be, the slides will be on the website and the recording will be on the website sometime next week. If you have any questions about that, you can shoot us an email at communityed@chconline.org. And so we have a set of pre-planned questions that we're going to ask. And then you also have a couple of index cards on your chairs. Feel free to write any questions you might have on the index cards, and we'll collect those. And then our plan is to save about 20 minutes at the end to go through some of those questions. I just also wanted to say a couple things. One is we do have an ADHD parent support group that meets once a month. Is that your group, Kendra? Yours is the LD one. Okay. So this group, I think, met today. I think they meet, tomorrow. They meet on Wednesdays. So this flyer is on the table over there if you're interested in the ADHD support group. Lauren has led that group in the past, and it's been a great resource for parents, and that's free. And then I just wanted to point out that we have a mini conference coming up. It's in February. It's at our South Bay location. There's a parent track on there that's talking about assessments and how to be your child's champion. Like, how do you understand your child's assessment? And then how can you use that information to really talk to people to help your child? So it could be your child's Little League coach, or even your spouse, or even your child's brothers and sisters, and all kinds of folks. So that's also over there on the table. So, excuse me, did you want to ask your question now, or do you want to, can you?
I don't use.
Sorry?
Okay to ask now.
So that's a good question. Let us go through these questions, and we might answer your question. But for sure, write it down on an index card, and we'll make sure. Okay. So first question. My child with ADHD is very impulsive, and this causes behavior issues at home and at school. So how can I help her?
I think that one comes to me. How many of you have kids that have behavioral problems at home? How many of you have them at school? And are the majority of your kids elementary age? Raise your hand if elementary. Middle school? High school? Right, so we've got a mix of a little bit of everything. When I do the parent support group, I really like to use the group to also talk about things that have worked and haven't worked. One of the first things that I talk with parents about when we're looking at how to kind of create some stability and consistency at home for kids that feel like they don't have a lot of consistency and predictability because of their impulsivity is really just looking at what your schedule looks like. And a lot of times in these busy days, we don't have really regular schedules. If you have multiple kids, you're probably driving all over the place for other kids' needs as well. And one of the simplest things I can tell people is to have schedules and routines. And that's the same at school as well. From a very early age, the kids go into school and they know where their backpack goes. They know where to hang things up. They know where to get the balls for recess, things like that. And as it goes further, we see more and more of what Glenn was talking about, the executive functioning problem, because kids have to transition. They have to transition from one class to the other, from one activity to the other, and frequently we see challenges with that, especially if they're hyper-focused on a preferred activity. So I would say really starting with the routines, and it can start from a very young age. One of the families I worked with who said, my kid's room, everything is everywhere, and he's a non-reader, and we just started labeling bins with pictures, and so they knew that their pants went in a certain drawer and their socks went in another drawer, their toys went in a certain place. So a lot of it is repetition and just really starting to think in terms of how do you structure the environment and the day. Timing is another element that I often talk to parents about. If you are going to the grocery store and you have your ADHD kid with you, you know that there is a certain amount of time that you have before everything goes south. Getting them engaged. Some of the kids, if you say these are the things that you're getting and bringing to the cart, can be really helpful because it gives them something to do during that time. If you're afraid that you will never see them again because they go get the item and won't come back, then I wouldn't recommend that.
Or that they'll eat whatever they get.
Yes. So, there are ways, knowing your child, of what's going to motivate them, what's going to be helpful. But I would say those basic things of really thinking about your family's schedule, your child's schedule, their attention span, their interests, those are going to be really helpful things, both at home and at school.
Lauren, Glenn, any additional?
Well, you mentioned the word. You mentioned the word, but I really want to emphasize that consistency is really the key here. It's not the only key. I mean, it's like, practice only makes perfect if you actually are practicing well. But so I usually tell parents, don't do anything that you can't keep up indefinitely. If you've got something that the first behavior chart I ever made for my kids was so complex that it collapsed of its own weight, and I was trained in this. You literally anything you think about doing, consider, am I going to be able to keep this up for the next 3 years? And if the answer is no, then you need to try to begin to simplify or to think about steps that will get you towards the simplification.
Yeah, I would add that I started out with advanced, behavioral charts, and those don't work, for at least for my child. So I think Kendra taught us that rewards should be instant, or a consequence should be very short, which is something, kids can't. It's hard for my son to work for something for 2 weeks, right? It doesn't have a great end result. So make things simple and focusing on maybe that week it's being kind to his younger brother, and that's the focus of the week, and setting up ways for him to be successful in doing that. So that's what, and same kind of goals for school, possibly, if you're having trouble at school.
Thank you. If you have written down questions on a card, while we're answering this next question, I'll kind of walk around through the group and you can hand them to me as I come through. Next question is, how can I best approach my child's teacher about my child's needs?
That's a tricky one. So I have found our teacher conferences to be rather rough. I've left in tears several times. I think having, we have been diagnosed with, or my son was diagnosed with ADHD at 4.5, and then we redid our diagnosis at 10. So I think understanding the accommodations in the back of the evaluation and really thinking through how you want to present it to the teacher. And I've had everything from a teacher who didn't believe that ADHD was a real thing to teachers now that are very helpful with what accommodations do you need. And you do, again, have to be a champion for your child. You have to be a little bit of a bulldog and a little more assertive than I was sort of comfortable being. But I think you need to think through what you want to ask for, and then see, what they can do for your child. And I would advise staying on top of it and scheduling meetings regularly, because and a lot of the teachers will do it, but you don't want to be pushy and, I only want to do my one conference. I would set up a quarterly thing with our teachers, and that was very helpful for me.
I feel like some teachers can be really proactive too, and they might say, hey, we're noticing during the day that there's more inattention or there's more difficulty focusing, and often they're the first people that let parents know that there's a problem. And you may already sense something, but it's really in those moments where you have to sustain focus and be around other kids and kind of follow the rules that we start to see more of the challenging behaviors come out. I will frequently, or have frequently in the past, had teachers that say, you know, they're manipulative, they're willful, they're defiant, they don't want to listen. And there's a lot of negative connotations or descriptions that frequently come with kids with ADHD.
Lazy, you left out lazy.
Yes, I was trying to be kind. And I think if you're being told that by a teacher, think of how your child's being treated by that teacher. And so really validating for your kid when they say something is hard or they think a teacher's mean, they might be asking them to do something that's difficult for them, but it also could be that there's some real feelings and energy behind that, because it's hard for a teacher to teach a kid with a lot of activity and distractibility in class, because it can disrupt the whole class. I often will say to teachers or parents, is it something that they are capable of doing, or are they competent to do this, and are they capable to do it? Because there are times when you may know what to do, but you may not be able to do it. And I think with our ADHD kids, they frequently want to do the right thing and know what's expected, but then in that moment, being able to do it can be a real challenge.
Can you address IEP? Is that, I don't know if you're going to address that later, but since you're talking
IEP, that is actually one of the questions, but we can talk about that now. Did you want to add a comment, Glenn?
Yeah, I was just going to say, at some point, if you feel like you've done everything reasonable and haven't thought about medication, that's a time to think about medication. I often actually encourage people to wait until they get to a point where they feel like their child is right at the edge of beginning to feel like things aren't going to work for him or her, because the ADHD medications that we have aren't curing anything, so there's no advantage of giving it early. But it's a little like, you don't take cold medicine before you have a cold. But when you get to a point where you've tried these things and the decision is my kid going to fail or do badly in this class or not, that may be a time to think about medication.
Okay, so we'll go right to the question about IEP. So where would I go to find out more information about 504 plans and IEPs? And when we say 504s and IEPs, everyone know what we're talking about, pretty much?
Is there anybody who doesn't know what a 504 or an IEP is?
Nobody wants to say now.
It's okay if you don't. There's several districts that provide parent education for parents. Certainly talk to your school administrators, your teacher, your school psychologist. But I feel like Parents Helping Parents, and there was another one you said, Chad, is that the other one?
Yeah.
Have very good resources. And now I'm going to sound like an old lady, but I feel like there's so much information you can gain online too, where you can frequently say, what's the difference between a 504 and an IEP? How do I go about getting a 504? I would be specific to California when
Yes.
you do those searches, because the laws are different in different states. But usually you do not have to have special ed testing to have a 504 plan. If your child needs accommodations, then you can request that if you feel like they need those to successfully access the curriculum. Often we see 504 plans because people have requested individualized education plans, the IEP, they've done the testing, and they don't meet the criteria, which is not a diagnosis. So your kid can have ADHD or anxiety or depression and still not qualify for services through an IEP. And that can be really frustrating because you go to all of these. I think the hardest thing, and you can speak to this, Lauren, but the waiting. Something's wrong, you want help, you're trying to seek help, and then a lot of the things have timelines of how long it takes to finish the testing, how long it takes to implement a plan. And so a whole year could go by, and you could feel like we're finally getting to the nuts and bolts of what's wrong and how we can help our child, and now they're moving to a new classroom, and we have to start with a new teacher and a new environment.
Absolutely. And I think there are a lot of wonderful online resources now. I know when my son was diagnosed, it felt like ages, and that, I think that's why we wanted to start the parent support group here at here at CHC, because it's wonderful to have a community of parents that right away can jump in and help each other, share tips and tricks, and it's a lot of people who have done a lot of research, and it's a great group. So I think things like that are things that can get you started while you wait, because it can feel like a long time to see a behaviorist. Or our evaluation, I think, was 3 months out, and you're getting all those calls from principals and various things, so it can be hard.
This is a time when what Lorna mentioned earlier is really crucial. You don't want to be shy and modest with this. I don't want to speak badly of schools. They have a lot of responsibilities, but there's a tendency for them to drag their heels. And there's this pattern I've seen far too often where the teacher notices some problems in the fall, but doesn't get around to mentioning it until the spring, and suddenly it's April, and boy, the year's almost over, and summer, nothing really happens. So, I mean, literally, you can have a year go by before things take action. So if you're really worried, and often teachers will ally with you, it's really the rest of the system that can cause problems. If you're worried, waiting until the school says, by the way, do you want to do something, is not the best approach. It really behooves you to say, stand up for yourself and say, my child is having a problem, and you can find out what letters to write and how to get the system started. You want to do that as soon as you really are convinced there's a problem, because everything else takes time and the clock doesn't start ticking until that occurs.
There is also, so Chris Harris, who's our Chief Schools Officer here at CHC, has done sessions here on IEPs, and those are in our resource library. So you can go to our resource library and just search IEPs, and he's done at least probably 2 or 3 of them. Yeah. Okay, so how about, big one, right? I know that medication is one option for intervention. How do I know if medication is right for my child? What medication options work well with kids with ADHD?
So out of curiosity, of the group here, how many have your children are on medicines of one sort or another? And how many of you have chosen not to use medicines? How many on the fence? Okay. So medications are viewed as the gold standard. If you look at the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry, which is sort of the 2 medical groups that are most responsible for deciding whether or not to use medication. There are lots and lots of studies, particularly of 7 through 10-year-olds. And more now of adolescents than we used to have, and sort of a growing amount in adults as well, that show that there are several medications that can be highly effective. The rough estimate is that 85% of kids will respond to a stimulant of one sort or another, and another 5 to 10% will respond to some non-stimulant medications that are out there. So, so there is a high response rate. The lovely thing about particularly stimulants is you get a very quick response, so you know whether or not things are better or worse. You don't have to wait for months. The downside is that they do have side effects. Although not treating also has side effects that we can talk about. When I talk to a parent, what I really look for is where is the problem, what kind of problem are we dealing with, and what kind of solutions might we be looking for. So if the problem, for example, is the child not turning his homework in after he's done it, which I can assure you I've got to experience that a great deal when my child was young, we don't have medicines for that. If the problem is that my child doesn't have any friends, we don't have medicines for that either. I do not have a friendship pill. On the other hand, if to the extent that the child doesn't have friends because he behaves in ways that makes it very difficult to be friendly with him, medicine may help under those circumstances. Not guaranteed. Certainly other things are going to be needed as well. So it really depends on when the problem is and what kind of problem is we're dealing with. The easiest one, and the one unfortunately that we probably got by far the most data for, is school-based. So for a long time, ADHD was thought of as a school-based disorder. The stimulants are really excellent for that because they last, these days we've got ones that last about the length of a school day. And if that were the only time kids ever had problems, that would be the only kind of medicine I would ever recommend. Unfortunately, I would suspect, because several of you probably have difficulties outside the school hours. One of the difficulties is that stimulants, the way they work, they have to wear off at the end of every day. So that's a good thing if all you're doing is giving it during school days. It's not such a good thing if you're having problems in the morning and in the evening or on the weekends. And then we end up looking at other kinds of things. So you basically, and also I mentioned 2/3 of kids have other kinds of problems as well. So if you get a kid with anxiety and ADHD, things get a little more complex. So you really need somebody who has expertise specifically in treating ADHD. That's usually a child psychiatrist or a developmental and behavioral pediatrician. Those are the two groups that have the most training. For so-called simple ADHD, where really it's just ADHD and no other kind of problems, pediatricians often are very confident and able to be, to be helpful with that. But if that doesn't prove to be enough, and that's where a lot of families start, then turning to an expert who actually works with ADHD and knows the medications that can be useful is really crucial.
Okay. So, what do you do when your spouse is not on the same page as you? Or even taking that to the...
with kids, right?
Or even, how do you talk with your, with siblings about...
How come he
Your
gets to be
child's
treated like special?
Sure. I think the sibling one is a really interesting one to tackle. How many of you have more than one child? And how many of you feel like one's being treated, the kid feels that the other one's being treated differently? Yeah. That's true with kids that don't have ADHD too, just so you know. I think that it's always hard because we put so much energy into our kids that have challenges because they're getting in trouble more often, or they're really feeling it emotionally, their self-esteem comes down. But the siblings are a really interesting group to focus on. Sometimes we see other secondary behaviors that come about with the siblings because they're trying to get attention. So really trying to balance your time with both kids and really recognizing that as much time as it takes to structure and provide this consistency for your kid who might be impulsive, it's also important for the one who might be, pretty independent or mellow or kind of self-sustaining to give them that same attention for just, being calm or doing what they're doing as well. I certainly think family work is helpful for both couples and families that have multiple siblings. There's a lot of families that have kids that have learning disabilities. I feel like I'm Debbie Downer tonight, and I don't mean to be at all. But it's stressful for families, and some families end up separating partly due to some of the challenges because there's a lot of arguing that goes on or people can't get on the same page. So really, the more that you can be united, you don't have to be exact in your parenting, but find that common ground. It really helps the child with the challenges as well because they feel like if they go to one parent, they're going to get the same general direction that they would from the other parent. Do you want to speak more to that too from a parent's perspective?
I would just agree with that. I think it's taken us years to get on the same page, and we still aren't. So I think it's the consistency that Dr. Elliott was referring to. This is how we're going to handle this. This is how we're going to, my husband used to come in and then be like, you're grounded for a week. And, I was the one staying home with my son. I was going, wait a minute, you can't do that. Like, I'm in charge here, So, it was hard and it would cause a lot of friction. So I think, yes, the punishments or the consequences being in alignment, how you're going to handle, how you're going to stay calm. Our son can be very volatile. So it's how you how you handle that and staying patient. And I think, walking away is hard. And I think, I think that a lot of us were probably raised with A to B parenting, where you did something, you got a consequence. And what's been challenging for my husband and I is realizing that our son with oppositional defiant disorder we need to parent in a completely different way. So the way we parent our younger son is not going to be the way we parent him, because the harder you go at him, the harder he comes back at you. So it's just a different type of parenting that with Kendra's help, we've sort of are still navigating, but we're getting better.
You're good.
And it isn't all negative. We have two boys who are 2.5 years apart, and my younger son is the one with inattentive ADHD. His older brother was actually popular but very shy, and by the time my younger son was 7, so his brother was 9, every weekend the older brother would come up with a list of kids he wanted to have come over, and then the younger one actually would do the dialing and invite everybody over. So they actually ended up making a great team, and some kids with ADHD turn out to be expert at video games, for example. So there are things that ADHD can be viewed as a relative strength, where you can use that to help socially and with siblings and some of that kind of stuff. How do I get over that level? Can sometimes be at least temporarily cause a truce.
Okay, I'm gonna go to some of the questions from the cards. Okay, so what do you think about sports or physical activity as an intervention for ADHD? Does it really help regulate hyperactivity or attention or impulsivity?
So I come from a family that was a very heavy sports background, and I think it really depends on your kid. The other thing I would say is that if your kid does not have the ability to have some self-control, they're probably going to fail. And so before you decide to put them in a team sport, they have to have the basic skills to be successful on a team. And that doesn't mean that it's not a great outlet to help them with their energy. Swimming has been a great activity that many of the families I work with feel like work well for their kids. If you have kids with noise sensitivities, it can be a problem if they end up competing, but often just the regular swimming can really help kind of regulate their arousal state. Some of the things too that aren't team sports, which can cause more frustration if things don't go their way, can be a challenge. But I think any kind of physical activity is really, really helpful. And I've worked closely with a lot of occupational therapists with kids with ADHD to help with regulation, and it's been really successful for a lot of kids too.
Yeah, I would completely endorse that. I think you really need to think about what the sport is and what's going to be required. I personally, and I'm sure there will be people here who will beat on me later, I find baseball completely incomprehensible why anybody would want to play it, but certainly the average ADHD kid does not. Sitting out in right field just turns out not to be much fun. And, not all, but some kids with ADHD also have motor clumsiness, and they're not necessarily going to be the most coordinated. I think the parallel kinds of sports like swimming, some forms of track, where there is a team component, but a lot of it is individual effort, makes a lot more sense. The other is that I at least have not found a way to compel somebody who has no interest whatsoever in moving to get involved in a sport. I think you can use positive rewards and that kind of thing, but it can be really difficult if your child isn't necessarily interested in going out and spending a lot of time in an activity. I know some families that make it a family affair, so they go out biking together, for example, or any other kind of sport where they, trampoline in the backyard, those kind of things. So I think the physical activity can be really helpful, and certainly there is, I wouldn't say it's curative, but giving a kid a break during homework, for example, to go out and do something physical for a while can be really help get the homework done a little quicker.
Yeah, I think, go ahead.
Well, so what works for us is I used to get out when my son was 8, 9, and we would do sprints in the backyard together, and we would race. And I found that just even that 15 minutes of really hard cardio would make the transition to school a lot easier, his ability to sit in his seat. So I even worked out something with the teacher to make him do that during times that weren't recess. So for me, the cardio has been very helpful. I would also add that because he is athletic, I do feel like he learned a lot about relationships through team sports, and if your child can handle the team sports and the dynamic of it. And I would also preface that's you talking to the coach ahead of time, setting the expectations of your child having ADHD so they don't scream at your child like, what's wrong with you? Like, why aren't you paying attention? So I've been lucky enough to pick certain coaches that understand ADHD and will work with my child. So I would encourage you to do that if you have a child who's interested.
And I think with the ADD child, I've had older kids who've been on baseball teams and club teams where they switch coaches, and suddenly it's a whole new world because the coach doesn't know their temperament. They don't know that they're listening, but they might not be registering with their eyes or kind of nodding. And so it was a lot of coaching for the kid to kind of say, how do you, with your whole body, let another person know that you are paying attention and you're interested, and how do you show that you're willing to do certain things, because the coach could take it as you're not interested or you don't care.
So there are a couple questions in here about autism and ADHD. So a child with high functioning autism and ADHD, he's receiving autism treatment. Should I also treat him for ADHD?
Yeah, so unfortunately, there's nothing protective with either autism or ADHD to prevent you from having other kinds of problems. The difficulty with autism, again, depending on the level of functioning, is trying to distinguish between whether or not the child is actually not paying attention because the material isn't interesting enough and the motivation isn't there to do something that the child doesn't really have much interest in, versus true ADHD. There are studies that show that some children with autism have both, and that the kinds of interventions that we're talking about work as well for somebody with autism. They may have to be modified somewhat because the motivational factors are going to be different, but certainly medications can work, although many children with autism, in my experience, are much more sensitive to medication. So you need somebody with some expertise to avoid making things worse rather than better.
And a lot of the things, like Glenn said, that somebody with high functioning autism, the executive functioning, the attention, the anxiety, those are going to be things that you're going to see with a lot of kids with ADHD that just have ADHD. So it doesn't mean because you have ADHD that you're on the spectrum, but there's a lot of the interventions that overlap and can be tailored for both.
So speaking of interventions, is ABA therapy helpful?
For ADHD?
Well, this was about autism and ADHD.
So I always, when people talk about ABA, there's a lot of different layers to ABA. And I used to joke that it was like saying
So ABA, sorry.
I'm sorry, applied behavior
Yeah.
analysis. So if somebody says, does psychology work, right? Then it's the difference between, does cognitive behavioral therapy work, or does this type of therapy work? And to me, ABA is more like the overarching behavioral principle. So if you're looking at changing behaviors and you see that a certain function is present and that somebody's trying to get attention or they're trying to escape or avoid something, you want to teach them an alternative replacement behavior. And so with ADHD, sometimes it's harder to weed out what that function is, because so much of it is more of the neurological piece where you've got kids that are moving quickly and doing things, and you can't always tell what's the trigger for some of those. Sometimes there isn't a trigger, it's just part of how they're moving throughout their day. So within ABA, there is a very kind of narrow path called discrete trial. And for lower functioning kids that have autism, discrete trial is really the basic of how you teach specific skills. And that wouldn't be appropriate necessarily for somebody with ADHD. But certainly the applied behavior analysis piece where you're teaching alternative replacement behaviors could be. And when kids get behavior plans in schools, they should definitely be based on applied behavior analysis. And if they're not, then it's not really a valid plan.
Thank you. So, going along with therapy intervention, what exactly is CBT and how does it really help?
You want to me with it? So cognitive behavioral therapy is really, and help me out if I'm, not including everything. It's the idea that if you change your thoughts, you can change your behavior. If you change the way that you think, it can change the way you feel. So often we're talking about
And behave.
Yes. And so often we're working with our kids who have impulse control to just kind of recognize how your body is, right? So how does your body feel? What is it like in this moment? And then trying to recognize when you're feeling more charged. So a lot of the occupational therapy, there used to be one called, and I'm going to call it the wrong thing, but it was how does your engine run? And it was to kind of figure out how your body could be compared to a car. Now the zones of regulation is very, very popular. And it's similar in looking at when you're feeling calm, what are the things that your body feels and what are the things you're able to do? And then when you start to feel dysregulated, how does that then impact you in different settings? So they kind of use a red, yellow, green analogy, and then they have blue if you're feeling sad or low. But a lot of those are really just kind of the cognitive awareness and the metacognition about your feelings, your awareness, your body, and how it impacts other people. So some of the other things that I use a lot in my work is more social cognitive interventions. And those are, again, thinking about how people think about you and how your behaviors impact other people. And it's kind of a way of teaching empathy, but also clear expectations. So we go back to this consistency and predictability that if you know what's expected of you, you still are going to have a challenge in keeping it together in those moments, but at least you have a better idea of knowing what to do. And this is probably a good time. I always talk to parents about when you're giving feedback, it's so hard, and I'm a parent myself, but like saying stop,
Isn't it so
don't
much
do
easier?
that. Yes, so much easier to tell other people how to do this, right? But you should be telling them what to do, not what not to do. And so if it's, and sometimes it's the things as simple as go clean up your room, and it's like, can you put your socks in the hamper? Can you put the books on the bookshelf? So really break it down into smaller steps of what you want them to do, not what you don't want them to do.
So the other thing I would add is we often think of cognitive behavioral therapy as something that we do to the child. That's not at all necessary. You can use exactly the same principles that Kendra just described to help the parents create an environment that's going to be much more supportive of the child. So I mentioned the work that Bill Pelham had done, and that really was the point of that. Yes, the children learned the rules as well, but they were in an environment that supported positive activities and rewarded them for that and gave them breaks and then made them do exercises and a variety of other things. So for younger kids, we really emphasize the work with the parents, but it's the same kind of principles, trying to figure out every time if, like for example, I don't remember with your son, but there's some kids where telling them in advance that something is going to happen is really, really useful. And if they know a day in advance, they can prepare themselves and the next day they're ready to go.
Yeah.
And if you spring them on it that morning, the day's ruined. There are other kids where the exact opposite is true. And pretty quickly, as a parent, you discover which type of kids you have, because it's pretty consistent. There are very few kids who flip back and forth. So there are other kids where if you tell them a day in advance, what that means is you're going to have a miserable day or two until the event occurs, because they're going to worry about what it is that they have to do and where they're going and what it all is going to mean. So knowing that about your child can help you pattern how you're going to help that child to do whatever needs to get done.
I would also add that therapy for my child wasn't extremely helpful before 8, but I think it's around 9 that we came to started with Kendra. And I think the biggest thing that his takeaway is what Kendra calls reading the room, and it's the child really thinks about their actions and what's been done to them. And it's really important to teach the child how did so-and-so, what were they thinking when they saw you arguing about whatever? And what was this person thinking? And what was the teacher thinking? And that was kind of a big aha moment for my child of thinking about how it really helped him with friends socially, right? And also behaviorally with teachers. I don't think he really thought about how he looked when he was arguing for 20 minutes about the call during basketball. Like he just was in the moment. So I think that CBT has been very helpful, especially at that age range before they start losing friends, frankly.
I laugh because I remember a lot of the kids I work with too, when you ask them what they think or what you think other people thought, and they go, they didn't see me. They weren't paying attention to me. I'm like, oh, everybody was paying attention to you. It's hard to miss, right? So their awareness is really important. And again, not to make them feel bad, but to help them just see, like, how do you want people to see you? What do you want people to think and feel about you? Because our kids have great attributes, and we want the people to see those, not these things that can be annoying.
So this is about behavior rewards and that idea of, rewarding. So we keep behavior rewards short, but then I wonder how to help our son learn about the rewards of perseverance.
It's a good one. Sometimes I do a combo of both. It's kind of like when you think about an allowance or getting money for something. Maybe you want to spend part of your money now and buy something, and maybe you want to save the rest of your money for something bigger at a later date. Some of our kids, if you do incentives that are more representational, like tokens or tickets or points, whatever it is, some of the kids will say, I want to wait and I want to get something bigger. Some of them obsess about those bigger items. And I think there's downsides to that too, because if our kids feel like they mess up, then it's like, now you're keeping me from getting my bigger item. And so recognizing that, I talk a lot about narratives with kids too, the older kids in particular, that, this is one moment in your day. And you can continue to have big reactions about this and kind of lose your momentum, or you can turn it around and get back on track again. And so for a lot of kids that have behavior plans or behavior incentives at home, it's not based on one incident. It's based on multiple incidents throughout the day where they have multiple opportunities to show that they're doing something well. And I think that that's really important. It shouldn't be an all or nothing. Safety is about the only one that I really kind of am strict with about that, because, I've tried to give analogies to kids, even the ones who like sports. I'll say things like, well, even, in hockey, somebody gets in a fight, they get kicked out after a while, or they're in the penalty box. So recognizing that you're not necessarily going to get free access to everything, but it doesn't mean that you have no access to things either. That's one thing when you're thinking about consequences, that our kids with ADHD, it's kind of like when the teachers take away their recess. They need that physical movement. They need that activity break. So if you're saying you're grounded for a week, you have to have within that things that they can do, because they need those outlets. And I think that's the thing when they talk about short versus long. Just be mindful when you're upset with them that we're more likely to give consequences that are maybe not as fair or reasonable either, because we're not calm.
Yeah, the other point is that this is a moving target. So there are a lot of kids with really severe ADHD where you may need to literally, in a school setting, give them a reward every 5 minutes. Obviously, that's not something that anybody's going to be able to keep up over time. So what you do is, once they've consistently begun to be able to make that on a regular basis, you then begin to spread it out with the eventual goal of maybe rewarding them once a day, or at least a couple of times a day. So the goal, one of the reasonable goals, but it takes longer than you think it's going to, is to help them sort of see that there's something that they can actually work towards that's worth working toward. But you got to keep it within reasonable sight. And for a lot of ADHD kids, particularly when you're first starting, that the moderate ones, like a half day to a day, a week is impossible. And telling a kid to behave for a week and you get something special on the weekend, for most ADHD kids, is just not going to work.
I think the perseverance piece too, when you get to middle school and high school, our kids are getting more aware how they're different than other kids. And that can be really difficult to keep that kind of growth mindset, and really recognizing, I try really hard to emphasize with the kids, you shouldn't be comparing yourself to other kids. You should be comparing yourself with yourself. so that if you know that this is what you're working on, it doesn't matter what other people are doing. And we say that, but it's so hard because we all do it. We compare ourselves to other people. And so for a child, it helps when the parents are reiterating that, and the teachers and the other support staff are also recognizing, like, this is a success for you. You know, last year at this time, you weren't able to do this, and now you are able to do this. And what's our next goal for you? Not for anybody else, but where you are.
So go back to the classroom for a minute. How do I know what my child with ADHD needs to be successful in the classroom?
There's a question.
I think it obviously depends on the child. I think that for us, depending on age, but right now, it's certain accommodations, I guess, are working for us currently. Meeting with the teachers, on-time tests, and also my son has a tendency to rush, so they're willing to take the paper back, hand it back to him, say, do you want to check this? Because maybe, you know, he didn't answer 3 questions in the middle because we sort of blanked out. So they will hand it back. So seeing what your teacher is willing to do accommodation-wise, depending on age, and that's what's been helpful for us.
Yeah, I think this is really where knowing your child, and this is where a thorough evaluation can be really extraordinarily useful, because we can get a lot of information about what specific needs. On-time test is a great case in point. So there are a lot of kids where on-time test is a complete waste of time because they're the first ones done all the time. And giving them 20 more minutes is not going to do anything. Whereas, like with your son, the expectation is that once you've thought you've finished, then you're going to go back over and maybe even initially need to notice that you did the front page, but you didn't do the back page. So there may need to be a little bit of education around what are you missing, and give them a chance to do that. So it really depends on what kind of difficulties your child is having. If distractibility is a huge problem, putting them in the back of the class is not a good idea. They may need to be up towards the front. Relatively trying to work out subtle signs so that they don't feel like they're being called out every time the teacher would like them to pay attention can really help. There, teachers who can just go and tap the shoulder, and that can work. And it's the sort of thing that the child can really participate in, because what would we need you to pay attention? What would work that wouldn't embarrass you, but gets the message across?
I also, just to add, I think that my son was very anti anything that made him look odd in front of the other students. So when younger, we had the kind of check happy face for the morning, afternoon, and late afternoon of how he did. And he was so embarrassed that piece of paper was on his desk, right? So you've got to work out something that works for him. But it's a lot of convincing as a parent of, your ADHD makes you an amazing athlete. Your ADHD does this. So you have to share those strengths with him and finally get your child to the point where they are comfortable advocating for themselves. And my son currently talks to his teacher about, he has no shame with the ADHD. He's like, Mom, everybody has ADHD. I'm like, okay, great. So now there's less embarrassment around it, but it took a lot of our help, Kendra's help, to kind of get him to the place where it's not so embarrassing, and that he's willing to talk to a teacher now that he's in 6th grade.
I think if you look online or in any of the books that are based on ADHD too, there are a lot of accommodations and suggestions. And what I would tell you is less is more, in my opinion. If you go in with your laundry list and say, we want all these accommodations, the likelihood of a teacher being able to do all of them is going to be really hard, right? They might do a few of them, but not all of them. And so really looking at them and know your child, or even talk with the teacher and say, are these things that you think could help them? With the executive functioning, I can't tell you how many times we've said having an agenda where it's being checked by a teacher so that you know when you get home what the assignments are. If it's a younger kid, having colored folders. Sometimes I'll say, forget the big binders with all the stuff and just have a to-do and a completed folder so that there's one place to look when you go in and a teacher can prompt. We don't want them prompt dependent, but the goal is that a teacher consistently prompts, I learned the routine. And then eventually we say, what do you need to do? And they're like, oh yeah, my folder. And then they don't have to prompt anymore. But it has to be set up in a way that is consistent. And when it doesn't, then that's when you start finding papers at the bottom of the backpack, or kind of a week later, a permission slip. And so really having a good system can be helpful.
Thank you. Okay, let's talk about twice exceptionality for a second. Consider topic. Gifted in ADHD. So my son's impulsive. I'm wondering, could it be ADHD sensory giftedness? It's just a 7-year-old boy with high energy. It's so complicated. So how do we even start to address that?
Yeah, so IQ, again, is not something that protects you from much of anything else, as far as I can tell, although it potentially offers you a nice advantage in the long run, because you hopefully have cognitive machinery that you're going to be able to use to figure out other kinds of problems. It really goes back to what is it causing problems, and what kind of problems is it causing, and under what conditions. If it's just a high-energy child who's bright, typically with a little bit of, by the way, have you noticed that the teacher's upset with you, ought to work. If there's unfortunately, there's also the issue of there are some teachers who just don't do as well with these kinds of kids as other teachers. And one of my favorites is we were testing a child, and the teacher filled out one of the questionnaires that we asked, but wrote, and had huge amounts of complaints about this child, but wrote at the top, I'm not going to help diagnose ADHD because I don't believe in it, and then wrote zeros for all of the behavioral, which was not very helpful. That's another one where I would tend to speak up. If you've got a real mismatch where you're convinced that the difficulty is the placement, not the child, that's a time to sit down with the principal or the counselor or whoever you need to sit down with and say, we have a problem, what are we going to do about it?
And I would say with 2E kids, this has been kind of a movement that has come up, and I'd say in the last 4 or 5 years, we've really heard more of it. But I find it so interesting, because a lot of the research shows that these kids also have this real kind of rigid cognitive mindset. And so when they want to do something a certain way, they get stuck on, this is the only way to do it, and it's really hard for them to forgive other people. They hold on to grudges a little bit longer. But if you think about someone who's super intelligent, they're also distracted by their own thoughts a lot. So this idea of it being ADHD, a large part of their inattentiveness is that they have so much going on that they're thinking about all the time. And so the rest of the class isn't necessarily going as fast as they are. So they may do the work and then have to wait, and the teacher's explaining it to someone, and so they're off doing something else, and then it can be seen as, oh, you're not paying attention, or you're being disruptive because you've moved on to something different. So really helping the teachers understand their needs, but also really creating challenges for them, I think can be really beneficial. And it's really a more tailored approach.
So there's a few questions here that might be kind of up your alley, Glenn. So talking about correlation between ADHD and some other things. So is there a correlation between ADHD, I'm going to say 3 things: prenatal alcohol exposure, prenatal cocaine exposure, meth exposure, all prenatal?
Yes, all of those. Alcohol also is associated with usually a lowering of IQ, but ADHD is certainly more common, not universal, but more common with heavy alcohol use during pregnancy. Not even all that heavy. I think 2 glasses of wine a day is plenty to cause problems. Cigarette smoking actually is also associated with an increased risk of ADHD. It's a little bit complicated because ADHD is an inherited disorder, and there may be a partial correlation between the likelihood of a mother smoking through pregnancy and having some ADHD tendency herself. Cocaine exposure and meth exposure particularly are associated with not only with ADHD symptoms, but with an especially hard to treat form of ADHD. Often the medications that we typically use don't work especially well, or certainly not as well as we would expect, and the behaviors are more intense, partly, possibly at least, because many of these kids are really hypersensitive to their environment, so they're much more overreactive to what we would normally think of as modest to mild stimulation. They view as overwhelming.
How about correlation between infant colic and ADHD, or nighttime bladder control and ADHD?
No, not a correlation with either of those. Colicky babies are, fortunately, we didn't have one, but once you survive colic, usually, which can be a long time, usually those kids do fine. They're not noted to have any major risk of other subsequent problems, other than being strangled by their parent, but that's a different issue. There was a guy who wrote a book decades ago now claiming that colic was actually a good thing, which I didn't buy. But anyway, I'm sure he didn't have a colicky child. The other one was bedwetting. Bedwetting is certainly not associated with ADHD. Bedwetting is familial. It usually runs along the dad's side. It's much more common in males than it is in females, as is ADHD, so it's not that unusual for you to end up with both. But you can have either or both, and they're really not, one is not associated with the other. What it takes to get over bedwetting may not be as easy if you've got a kid with ADHD, because they may not remember to go to the bathroom just before, or not drink water just before, some of those kinds of things. So it may be harder to get them into the routines that are needed. There's an interesting issue of sleep. A lot of kids with ADHD have sleep problems, trouble getting to sleep, trouble staying asleep, and there may be some association with sort of, again, with the difficulty of overcoming bedwetting because of the sleep kind of issues.
I just want to add that one of the things that is difficult is that there are lots of symptoms that overlap with ADHD, anxiety, and depression, and trauma-related issues. So if you have somebody who's experienced trauma, they might have higher anxiety, difficulty focusing, separation anxiety, and they might have bedwetting problems as well. And so it's really hard if you just look at the symptoms to say this is what we think the cause is, because there can be several symptoms that match different diagnoses.
That's why we need a blood test.
Someday.
Okay, going back to kind of how do I help my kid? So how do I help my kid stay with just one task and finish it?
Mindfulness. So mindfulness is kind of a buzzword that, again, has come out, I would say, in the last 5 years in working with kids. And I'm a big proponent of it because I have my own distractibility moments, and so I found it really helpful for myself. But there's an idea of being one mindful, and that's that you do one task at a time and you really focus at it from beginning to end. So for so long, I feel like people have said, I'm really good at multitasking. And what we really want kids to do is to be able to be completers. We want them to be able to finish what they start. And so if they get off task, really having them go back and not focus on other things, but return to the task at hand and helping them really think about it. You may need to break that task into smaller chunks because it may be too big for them, but helping them understand that the completion of a task is partly by directing their mind and turning their mind to that task when they feel distracted.
And I mean, one of the things that we can encourage, because we were talking before, and this is one of those delicate balances, but you also want to help them know when they need a break before they can continue the task, and keeping those short, making sure they don't get absorbed in something else that's going to prevent them from coming back to the task, but helping them feel confident that they can eventually be responsible for saying, I need to get up and stretch for a bit or go run sprints, and then come back. And that's a goal. It may take a while to get there, and for a long while, you may have to be the one to sort of recommend that, or it has do it on the clock or something like that. But ultimately, what you really like is for them to say, "Wow, I'm getting to that point where I need to stop and let my brain rest for a minute before I get back to the task." But absolutely agree. There's a guy named Russell Barkley. If you're not familiar with him, I would strongly recommend. He's written a number of books. Turns out he had a twin. He died recently. Had a twin who had severe ADHD, and he spent his entire professional life studying ADHD of all ages. And he's got a book recently about sort of more strength-based kind of approaches to ADHD. And one of the suggestions he had, which I don't know if you've seen it, Kendra, I found it fascinating, is that he recommends sort of having a timer for how long you're going to spend on homework, for example. But rather than sort of extended time, he says keep the amount of time that you would regularly. But if you need a break, you put the stopwatch on hold, have your break, and then you come back so that you know how much time you've spent on getting the homework done. So it's a different way of sort of thinking about how to organize yourself. And so the kid can complain that, this took me 5 hours, and you can say, well, no, it actually took you an hour. What took 4 hours was all of the things that you did. And so maybe we could think about that.
And what works for us is we kind of get homework done. We take a break after school, we run around, and then we get homework done. And his process is standing at the kitchen island, and he's drumming with his pencils, and he's moving his body, and whatever works, right? You don't need to sit at a desk, and that's why school probably is a little harder, because you can't do that at school. But I think it's also we set sort of a reward at the end of that homework, so something to look forward to, and splitting it into pieces, as Dr. Elliott said, and taking breaks. But he likes to get it done, and I think, again, the structure, this is how the day is going to go. We have the same routine every time, so it becomes less of procrastination, which for big projects and things like that is always an issue.
Yeah, you can, particularly as your children get older, you can let them experiment. My son's way of studying, I literally could not stay in the same room. He would have a radio on, usually was at his computer, was doing back then whatever they were, message groups or bulletin boards or whatever they were before we had chat rooms. Literally, for me, it was completely overwhelming to be there. For him, it was kind of this cocoon. He had the fan on, and it was this cocoon in which he sat in the middle of the eye of the storm and got his homework done. And from my point of view, getting the homework done was my metric, and as long as that worked, that was great. For another kid, that kind of environment would be absolutely impossible and chaotic. So. And it's parents, nobody's asked, but parents often ask about video games. My opinion about video games is what's the impact of that video game time on the child. There are some kids that can play it for a while, be done, move on. There are other kids who turn into demons by the end of it, and obviously you're going to treat those very differently.
Okay, we have about 5 more minutes, so I'm just gonna do 2 last questions, and I apologize. I know we did not get to everyone's questions, but I tried to kind of organize them, so I hope we hit
Did we get
most
to
of them.
hers?
I think so. We're getting there? Yes, okay. So, okay, so these are 2 kind of back to medication. So I'm gonna say both of them, and you guys can figure out how to answer. So can medication make behavioral or other interventions more effective? And then is there evidence, where it was, our child was diagnosed with ADHD at school when he was 7 or 8. How is ADHD diagnosed, and how do we start medication without a diagnosis from his doctor? So both kind of medication questions.
Yeah, but very different ones.
Yes. Go for it.
So, I'm sorry, repeat the first one?
The first one, can medication make behavioral or other interventions more effective?
Absolutely. That is one of the few non-controversial things I think we can say today. That isn't to say that medications are necessary for everybody, or that they should always be turned to, but imagine if you've got a child who has a reading disability and also a very short attention span. There is no question that if you can help with the attention span, the boredom of having to do the things that one needs to do to learn how to read is much more tolerable and much easier to get done. And I would say that really is across the board. If you've got a kid who's less impulsive, who's more attentive, and who's not as hyperactive, almost any task you can think about is going to be easier to teach than if you have a child who has all of those things.
And I just want to add that doing this for many, many years, I often am the first line of intervention where people say, well, nothing's been done yet, so we want to try behavioral intervention or therapy before we go with medication. And some of the kids I work with come back year after year because there's environmental changes or different things. But to see kids suffer and really, really suffer in school and in relationships and in their relationships with family members, and to feel really, really down on themselves and feel like things from they're crazy to, I can't do this, other kids are better than me, and to then have a successful medication intervention where they can now stop and think and have some self-control and some advocacy is amazing. And it makes all the difference. And so when I feel that parents are really struggling with that decision, I try and go back to that example because none of us want our kids to suffer. And it doesn't mean that it's a magic wand and it's a quick fix, but it means that it slows down what's going on in their brain to really be able to use the skills that I'm trying to teach them.
Personally, too, I think that we were on a non-stimulant at 8 years old because my son literally, physically could not sit in his chair. So I think the non-stimulant helped with friends. It helped with the anxiety he was feeling. He said it was his engine was running so fast that he could barely sit still, and it was painful, according to him, to sit still. So the non-stimulant worked very well for that, and we pushed off doing stimulants until about 4th grade, where the feedback was he was staring out the window all the time. So I know we don't take stimulants on the weekends. I can see a big difference between my son's ability to focus on the weekend versus the weekday, and I believe that there's no way we would be getting A's in school if we weren't on medication. So he finds it also helps him, and when he feels more focused, he is happier. So it's been great for us, just us personally.
Years ago, I had a patient who probably is the only patient I personally have worked with who had a very vigorous, good response to the Atkins diet, which has been around forever and involves avoiding dyes and specific kinds of foods and a variety of other things. And this kid had been on it from age 8 until age 13, and how the mother kept him on it is beyond me. But at age 13, he said, "Mom, I cannot take this diet anymore because it doesn't work. I can't go along with other kids because I can't eat their foods and all of that." And reluctantly, they came in and we talked about medication. It turned out that a very, very low dose of a stimulant actually had exactly the same benefit. He was then able to have a completely uncontrolled diet and everybody was happy. And fortunately, I can't promise this for every child, but in his case, actually, very little medication turned out to work as effectively as all of this intervention that they had been doing for 5 years. The other question, I'm not sure, speaking as a physician, but also as a parent, I'm not sure I would want a doctor who would be willing to prescribe a medication without a known diagnosis. In the first place, that arguably would be malpractice, but also if you don't know what you're treating, it's very difficult to know what treatment you ought to be doing. There was a period of time before hard as it is for me to believe, before my time in the 60s when Ritalin, methylphenidate, was first introduced, whereas actually was billed that way. It was sort of viewed as a silver bullet. We often joke about silver bullets. So the idea is that you give this medicine to the child. If the child gets better, that proves he's got what was then called hyperactivity and that he needs this medicine and that's going to fix him. It wasn't until about 10 years later that a researcher actually got some friends of hers to agree to let their normal children take stimulants, and it turned out that they reacted very similarly to kids with ADHD, not as robustly because they weren't as hyperactive or as impulsive, but they were quieter, they were less physically active, they were more attentive. So it turned out that it was by no means a silver bullet in the sense of diagnosis, and diagnosing by medication response is a very risky kind of way to go because not everybody with ADHD responds well to medication, to the medications we have to begin with, but also there are lots of other conditions that might respond to medications and not be ADHD. One of the questions which I have a little trouble with is if a third of kids have just ADHD, why go through all of this testing? And if really the kids seems to be doing well academically, there's not any evidence that there's sort of issues around math problems or English or whatever, I don't think it's unreasonable to go to a pediatrician. Usually the teachers will provide enough information that the average pediatrician will say, well, let's give it a try. I don't think that's an unreasonable step to take. If it doesn't work, which you should know within certainly a month, probably within a couple of weeks, then I think it's time to begin to up the ante and begin to say, okay, let's get a more definitive kind of workup and a more extensive kind of assessment. But
I think the question was, where would they get that?
pediatricians. I mean, if you're convinced it's ADHD and nothing else, go to your pediatrician, describe the behavior. He or she likely is going to be willing to prescribe a stimulant, and you can get a sense of whether or not it makes things better.
They may also say or refer you to a psychologist for further evaluation or a neuropsychologist if
They
there's
might.
other things
Yeah.
that are more serious and aren't just ADHD.
Hopefully.
So it is after 8 o'clock, so we need to wrap it up. And I just want to say, so there are lots of good questions here. I'm just going to read them quickly.
Okay.
Are you available to stay around for 10 or
But if
15
people
minutes?
need to leave, that's okay.
Yes, go ahead and leave. So I'm just going to go through these. So because there's screen time, which you alluded to, how does screen time affect ADHD behavior? What about the addictive kinds of aspects of that? Does the school need to conduct an assessment for 0504? You can also find that in our IEP at Chris Harris, his IEP presentations that he's done. So those are in our resource library. If the child has ADHD along with dysgraphia and dyscalculia, does medication or therapy help? What kinds of therapies? Looking for qualified therapists who are also psychiatrists. That's specific, but correlation of that addictive behavior screens with ADHD and the treatment around addictive behavior. Evidence about ADHD prevalence has increased in recent years. Is it true? Is it that ADHD prevalence has increased, or is just the diagnoses
Yeah,
increasing?
let me answer that one quickly. Nobody believes that, unlike autism, where there's a huge controversy about whether it's increased or not, ADHD, there's no controversy about it. It is clear that we've changed the definition, and that's the reason it's more common. If we go back to the criteria that we used previously, we get exactly the prevalence estimates that were there present before. So it's a matter of where we choose to draw the line, and frankly, that's a political decision, just like hypertension is. So not so long ago, the Heart, Lung, and Blood Institute changed the definition of hypertension, and what I was a med student was taught was normal hypertension is now called pre-hypertension, 120 over 80, and now 25% of the population is either hypertensive or pre-hypertensive, which is great for the institution because, after all, who wouldn't want to treat something that 25% of us have? ADHD is a little like that. There was a point where CHAD, which which is a parent-run organization, was actually pushing for an estimate of 20% of children and adolescents having ADHD. Nothing really to support that, but you can. This is not one of these where you've got a sharp break and you can say, okay, this side of the line they don't have ADHD, and this side of the line they do. It's actually a nice normal curve, so you can draw the line anywhere and you can make it as big or as little as you want.
So there's also a question about the pros and cons about telling a young child, like a 5-year-old, about his ADHD.
Oh, great question. You and I haven't talked about this. I strongly, even with older kids, I strongly discourage letting them tag themselves as I can't do that because I have ADHD. What I recommend is focusing on the behaviors that are causing difficulty. You have trouble sitting still, you have trouble waiting your turn, those kinds of things, which are much less stigmatizing, much more actionable than this big thing of I can't do that because I have ADHD, and much less likely to get them into difficulty because they're going around either bragging or complaining or whatever they choose to do with the label. So I'm not opposed to labels. I think they can be very helpful diagnostically and in terms of thinking about treatment, but I'm opposed to kids being sort of using that label for.
I think it's also important to emphasize the strengths. So
Yeah.
everybody learns differently, and some people learn better using certain modalities than others. And so instead of focusing on you have this deficit or this is a challenge for you, focusing on this is the way you learn better and this is the way other people learn better, and we all have our differences in how we acquire information.
Yeah, so a concrete example of that is some kids with ADHD have a lot of trouble with visual and absorbing visual information, but do great with auditory information, and sometimes it's the reverse. And that's one of the reasons for doing testing, because you can actually find out if that's true for your particular child. That's not a disability. That's a. I mean, I can't draw with anything. So if I had to communicate by drawing, I would. I wouldn't be where I am. Fortunately,
So I don't want you on my
learned,
Pictionary
I learned to
team.
type. No, you do not want me on your team. So yeah, I think you're exactly right. Sort of both describing what they're good at doing and how they can use that, and also where it's going to be harder for them and they can learn.
I also created a kind of a vision board of the people that my son, Albert Einstein, Michael Phelps, Adam Levine from Maroon 5, a lot of people on, I put a lot of different people on there that are successful. And I think we talked to him about 7 or 8, and there's a great book, Driven to Distraction. It kind of if you haven't read it, you should as a parent, because it explains how it's written, of how it feels to have ADHD. And that was really an eye-opening book for me. And I think my son knew early on there was something going on with him. So I think it's confirming as a parent to, carefully, word it and don't let it be an excuse. But I do think you have to have multiple conversations over the years about that. And I think it was a real positive kind of describing it to him. Driven to Distraction.
Yeah, I will caution you. There's a questionnaire in the back, which I suspect everybody in this room, if you take it, you're going to diagnose yourself with ADHD. So be a little careful with that.
Okay.
But it is a great book. And there's actually a subsequent book. This is focused more on adults. There's a subsequent book by Rady and Hallowell called Beyond Distraction, which is more focused on, okay, you got it, now what do you do about it? And how's it going to affect you?
Okay. Glenn, do you want to say 2 sentences, something about screens and on impact on ADHD?
So there's a lovely site called Common Sense, which I strongly recommend to anybody who's struggling with this. It involves not only video games, but also phone use and a variety of other things. There is a fair amount of research on this, and it's much more benign than most of us actually, I think, would have expected it to be. Again, part of the problem is that there undoubtedly are some individuals for whom screen time is toxic. But the vast majority of kids really enjoy it, but that doesn't necessarily mean it's going to destroy their life. And in fact, it can be a very, sometimes it's about the only reward that really works for some kids. So you sort of have to, one of the first kids I worked with in a behavioral way was a kid who was addicted to computers. Literally had to have this was before Apple had made computers readily accessible. He had to have one of these clunky computers next to his bed, or he couldn't go to bed at night. He had school refusal. They'd actually, his grandmother had created a school because he'd been kicked out of his regular school, and he was attending this school and was about to be kicked out of that when I got involved. And what we did to get him back in school was to offer to let him have the iMac, which was about to come out, and that was enough of a reward that it actually was able to get him over the hump and get him back in school. I think, again, I think there's a lot of individual variability. In general, young kids, I think exposure should be quite limited. The American Academy of Pediatrics, which has a very nice, robust site for parents, has quite specific recommendations about sort of the amount of exposure at different ages that is generally acceptable. Anything less than that is probably better. But, I mean, you know, it is a reality. The likelihood that you're going to be able to keep electronics out of your child's hands until they turn to adulthood is zero. So thinking about how to do it responsibly and how to build it into part of your expectations and part of their daily life, I think, is really crucial. There are a lot of kids, I think it's perfectly reasonable to say no video on during the week, or very limited video during the week, and we'll give you a little more time during, you know, on weekends. But again, part of it for me, it's what it does to the child, and that's partly what kind of games they go to as well. There are some kids where that's where they get their socialization, because these massively multiplayer games give them an opportunity to be on an even footing in ways socially that they would not be if they were sitting there face to face playing a game. So it's not all bad, but if your child comes out worse than he goes in, that is an observation I would make, and I would have discussions about how we're going to modify that so that that's not true anymore, and that would be Kendra. I would send them to Kendra, and Kendra would fix it all.
So we're going to stop here. If you haven't, we would love it if you would take a minute to give us your feedback on the survey. We're able to provide these sessions free of charge because of generous donors, and so part of our responsibility to them is data and reporting back to them on you know, what their donation is doing. So we love the feedback. Also, Kendra did bring a few books up here if you're interested in. These would be resources that you might be looking at: ADHD checklist, learning outside the lines, social behavior mapping, all kinds of resources. If you're interested, you could probably just come up and take a picture of the cover with your phone.
Look, but don't take.
Yes.
And I'm at least happy to stick around if people have questions.
Dr. Elliott mentioned Russell Barkley.
Yes.
And if you go on YouTube, amazing.
Yes.
He's not a grandparent, but at least it explained things. It explained what Lauren's trying to do in her daily life.
There also, and unfortunately, I am not literate enough to be able to tell you one, but there also are some now very nice sites of people with ADHD who have regular blogs.
Yeah.
And some of those are really, particularly when you're dealing with teens, are just extraordinary opportunities for teens to sort of get a sense of, wow, maybe I can survive this after all.
Okay, thank you.